This is Chapter 64, Care of the Patients with Diabetes Mellitus. So this is a chart basically of how insulin gets used. You have the beginning of proinsulin. Your active insulin is a protein. It's made up of 51 amino acids, and it's initially produced as inactive proinsulin. Now, this proinsulin is secreted and stored in your beta cells of your islets of Langerhans. There are two types of cells that are actually there. You have alpha cells. Your alpha cells secrete your glucagon, and glucagon is what we call a counter-regulatory hormone. That basically means that its actions are opposite of those of which insulin are. Glucagon prevents hypoglycemia by triggering the release of glucose from where they're stored in their cells. Insulin prevents hyperglycemia by allowing the body cells to take in, use, and store carbohydrate, fat, and protein. So we start again, like I said, with this proinsulin. It's basically a prohormone that contains additional amino acids, and then it's converted into an active insulin by removal of the C-peptide. So again, the proinsulin is secreted. It's stored in the beta cells of the islets of Langerhans, and all of these are in the pancreas. It is then transferred, formed by the liver into active insulin. The insulin then attaches itself to these receptor sites on the target cells. Your target cells can be anything from your hormone cells to muscle, heart, and then it promotes glucose transport into the cells to the cell membranes. So basically it jumps on those cells, it glides through those through the cells and then into the cell membranes. So just to discuss our types of diabetes for a moment, we have type 1, type 2, and then of course gestational diabetes, which is through pregnancy. Type 1 diabetes is generally your insulin dependent. It's an acute onset before age 30. It's a process of where those beta cells that produce the insulin are destroyed by a type of autoimmune process. And the patients with type 1 diabetes are ketosis prone. With type 2 diabetes, it's usually older than 30. Most of these patients are obese or overweight. They have a decreased sensitivity to insulin, or there is a decreased insulin production. Something may be going on with the pancreas, or there may be issues with the liver. Ketosis is rare. This is generally treated with diet and exercise, and possibility with oral hypoglycemic agents. With gestational diabetes, we see this with pregnancy, usually the second or third trimester. It is considered a high risk pregnancy, and it's generally with a fasting blood glucose of greater than 100. And with a couple of risk factors for type 2, parents or siblings with diabetes. Again, obesity, at least 20% or more of the ideal body weight. African American and Hispanics are at higher risk. Hypertension and high lipid levels also put you at higher risk for type 2 as well. Remember as well that diabetes, the main feature is chronic hyperglycemia. You are always running a high blood sugar level, generally greater than 250 to 300. This results from glucose regulation, which basically means that you either have a reduced insulin secretion, your cells cannot secrete the amount of insulin that you need, or reduced insulin action, which means that there's not enough insulin and they're not being brought into the cells properly. Your insulin is secreted every day directly through your liver in a two-step manner. It is secreted at very low levels when you are fasting, like after you go to bed at night or if you're preparing for a test. And then at about after you eat, which is called your prandial period, it starts to increase, and you have this burst of insulin about 10 minutes after you eat, and then it slowly tends to increase after that until your blood glucose levels return to normal. So remember that after you eat, your blood glucose levels will go up. The liver starts releasing little by little more levels of insulin until your blood glucose level returns to normal. Glucose is your main fuel for your central nervous system cells. The brain cannot produce or store very much glucose at all, so it has to have a continuous supply from the blood circulation to help prevent cell death of your neuron in your brain cells. There are other organs that can use glucose and fatty acids to generate energy, but your brain cells and central nervous cells are not one of those organs. So I put this slide in here just to list some of the more appropriate diabetic symptoms. These patients are always tired, they're fatigued, frequent urination, sudden weight loss, always hungry. You have erectile dysfunction. For men, women can be more at risk for vaginal infections due to the increase in their blood glucose levels. Blurry vision or double vision, depending on whether you're hypo or hyperglycemic. Always thirsty, and then of course the numbness or tingling of hands or feet that come from the diabetic neuropathy. So in the absence of insulin, we have a number of problems that can occur in the body. So just to talk about insulin for just a moment. Insulin has many effects on your metabolism system and every cellular process that involves the majority of your tissues and organs. The main things that you see with insulin is it helps to stimulate the amount of glucose that your skeletal muscle and your heart muscles take in. It also suppresses the liver production of glucose and of your LDL, which is your low density protein. Your low density proteins are your bad lipids, and it helps to seduce the production of that. In the liver, insulin does promote the production and storage of glycogen, and at the same time it inhibits glycogen production into glucose. So also with insulin itself, I said a few minutes ago that glucagon was your main counter-regulatory hormone. Remember, that's a hormone that does the opposite of insulin. A couple of others are epinephrine and norepinephrine and cortisol and growth hormones. Glucagon and these other counter-regulatory hormones in combination with insulin help to keep your blood glucose levels in a range of about 60 to 110, and this helps to support your brain function. Just remember that glucagon causes glucose release from the liver. Okay, and liver glucose is made through the breakdown of glycogen to glucose and the conversion of amino acids into glucose. When liver glucose is unavailable, your body starts to break down fat and proteins to help provide fuel for energy. So when you're starting to see like ketones in your urine, then that means your body is basically being starved for insulin, and your liver is breaking down those fats and proteins. So hyperglycemia, as most of us know, is high blood glucose levels, generally above 250 to 300. It can cause fluid and electrolyte balances. And then we get the 3 P's: polyuria, polydipsia, polyphagia. Polyuria, of course, is excess urination. It results from diuresis in the osmotic system. You can have excess glucose then in the blood and urine. Polydipsia is excess thirst. And then you have polyphagia, which is excess eating. So we have excess urine, excess thirst, and excess eating. And despite the eating, this person still will remain in what we call cellular starvation. Those cells are starved for that insulin because the insulin is not able to move the glucose into the cells. Like I said a few minutes ago, with the insulin deficiency, your fats and your proteins start breaking down, and that's when you see ketone bodies, which are your small acids, showing up in your urine. Your ketone bodies are just abnormal breakdown products that collect in the blood when insulin is not available. And you can also have dehydration with this. The ketone bodies, I don't think I said provided a backup energy source. And I did say they were abnormal breakdown products, but they're used when insulin's not available. The ketones are what show up in your urine when you do the dipstick. So the ketone bodies are the breakdown and used for backup energy source, and then the ketones are what show up in your urine. You can also have hemoconcentration, which is when you have a concentration of your fluids and your blood in the body. You have thick, concentrated blood. Your tissues aren't perfusing right. You get hypoxia. The tissues aren't getting oxygen, especially to the brain. These cells don't metabolize glucose efficiency, so you have a buildup of lactic acid, and then you have more acidosis. Hypovolemia is a condition of just a decreased blood volume. You see this when patients are like in car wrecks and have trauma. Hyperviscosity is just really, really thick blood. And then hypoxia, of course, is cell death. And then the hypoperfusion is basically where your tissues are just not perfusing like they need to be. Acidosis is present because of the absence of insulin. You have increased hydrogen ions and increased carbon dioxide levels in the blood. It causes a metabolic acidosis. And then the Kussmaul respirations we talked about a little bit this past semester. Because the patient is trying to blow off that carbon dioxide and acid, they'll get these really weird respirations that they sorry about that. With the Kussmaul respirations, you will have an increased respiratory rate, and you'll also have a deeper respiratory rate because they're trying to blow off that carbon dioxide. And you can also, these patients can have what they call a rotting fruit odor. A lot of times you'll see this with DKA or diabetic ketoacidosis. You'll smell kind of like a fruity breath. This is another slide I put in to just list some of the other symptoms that were on the other slide, but it also shows some of the complications on here, like the diabetic feet because of the sensory loss. You can run into diabetic ulcers. These patients don't have a feeling, they can't feel cold or hot or when something is sticking into their foot. So they're at risk for infections. They're at risk for diabetic ulcers. You can have nephropathy, and then, of course, micro and macrovasculation problems, which we'll talk about shortly. And then, of course, prevention, keeping a normal body weight, a healthy diet, keeping away from the sweets. Exercise is one of the key things in helping control diabetes because it, number one, helps to control your rate. It helps to control the way your body metabolizes carbohydrates, and then, of course, not to smoke. So some of the chronic complications we see of diabetes, again, macrovascular and microvascular disease. Macrovascular, of course, occurs in your large blood vessels. Microvascular occurs in your small blood vessels and tissues. Macrovascular complications include coronary heart disease, cerebrovascular disease or strokes, peripheral vascular disease. All of these can lead to an early death. Microvascular complications are things like of the blood vessel structures and function lead to neuropathy, where you have all of your kidney dysfunctions. Neuropathy, of course, your nerves are not functioning like they are. And then, of course, retinopathy with vision problems. Realize that because of the chronic hyperglycemia, all of your membranes around your major organs thicken. That's what helps to cause the organ damage. The glucose toxicity also affects the cells and the way they function. And then you can get a lot of ischemia or tissue dying in the small blood vessels, and that causes connective tissue oxygen deprivation. Retinopathy is, of course, strongly related to the duration that a patient has diabetes. After 20 years with diabetes, nearly all type 1 diabetics have retinopathy, and most with type 2. You see very few signs and symptoms of retinopathy until these patients start having vision loss. They get blocked retinal blood vessels that causes them to leak, and then the retinal tissues are deprived of oxygen. They can have a lot of structural issues. They can have edema in the eyes. They can have fatty deposits, retinal hemorrhages, just a number of different things with the retinopathy itself. So it's important for diabetics to have yearly eye exams. Of course, we've talked about nephropathy in the past with kidney dysfunction, because with the diabetes, almost every organ is affected, especially the kidneys. With the nephropathy, you have a change in the size of the kidney. It reduces the kidney function, and that's what leads to the kidney failure. Of course, diabetes is the most leading cause of chronic kidney disease. One of the early signs and symptoms of nephropathy is microalbuminemia. That's small amounts of albumin in the urine, and then you're going to have elevated uric acid levels. So again, if you've got a patient who you even think is a diabetic, you need to be checking their albumin levels and their uric acid levels at least on a yearly basis. These patients also have high blood pressure, a lot of them. So again, that decreases the kidney tissue perfusion, and again can cause renal failure. And the blood vessels become really leaky, especially in your glomerulus. So then you're having a lot of protein and albumin that's depositing into the kidney itself. Kidney damage is related to the hypertension for patients, so that's why we need to get the hypertension under control. With neuropathy, we talked about that a little bit. These patients get diabetic neuropathy in all parts of their body. It is very slow. It's progressive, and this is not something that these patients are able to come back from. There's not a way for that function to return to normal. So with macular vascular complications, the main two are cardiovascular disease, and then of course the risk for stroke. Cardiovascular disease reduces a patient's lifespan, and patients with diabetes generally will die as a result of a thrombotic event like a clot. Usually the patients will have a large heart attack, and they can also be more at risk for left-sided heart failure. Patients who have diabetes are at increased risk for cardiovascular disease. Women are more affected than men, and cigarette smoking, of course, is an increased risk factor, and also a positive family history for cerebral vascular disease. Again, kidney disease is indicated by albuminuria. That also, the presence of albumin in the urine increases the risk for coronary heart disease and mortality from a stroke. Patients with diabetes often have higher levels of C-reactive protein, which is CRP. That's an inflammatory marker, and a lot of times it's elevated if a patient has had a myocardial infarction or have any type of cardiovascular problems. Realize, we've talked about cardiovascular issues before. Exercise, good healthy eating habits, reducing their stress will definitely help maintaining their blood pressure. Cerebral vascular disease, the risk for stroke is 2 to 4 times higher in people with diabetes compared to those that don't have diabetes. They're also at increased likelihood for carotid atherosclerosis, hypertension, hyperlipidemia. So like I said, it affects every body system. Patients who have diabetes do not need to be drinking alcohol because alcohol affects how insulin is metabolized in the body. If their diabetes is under control, then they can have, at least one alcoholic drink a night if they need to, but it's definitely not recommended. So we've already talked a lot about this underneath the microvascular. You can have eye and vision complications. Hyperglycemia causes blurred vision, and hypoglycemia can cause double vision. Cataracts can occur at a younger age, and they progress a lot faster along those patients that have diabetes. We've already talked about the neuropathy and nephropathy, and then men, due to the lack of blood flow, can get erectile dysfunction a lot more easily. Metabolic syndrome is also called syndrome X. It's simultaneous presence of metabolic factors known to increase your risk for developing type 2 diabetes and cardiovascular symptoms. So some of the signs and symptoms that can be present from metabolic syndrome, of course, are abdominal obesity, a weight circumference of greater than 40 inches, hyperglycemia, fasting blood glucose level of 100 or greater, abnormal A1C. Hemoglobin A1C is a blood glucose level that it tells how your blood glucose has been running over 3 months. It's a blood test. Most physicians want them between 4 to 6. So your book says an abnormal A1C between about 5.5 and 6. Patients having hypertension, blood pressure greater than 130/85, and then, of course, hyperlipidemia, your triglyceride levels greater than 150. So having any one of these problems plus having cardiovascular disease is called syndrome X, and it puts you at increased risk for type 2 diabetes. Patients don't need to be smoking. They're at increased risk for stroke, coronary artery disease, and early death. So health promotion and maintenance, we all know that we need to control all of those signs and symptoms, blood pressure, obesity. They need to be exercising. eating healthy, not drinking, quit smoking if they are currently smoking. Patients need to follow up with their physician on a regular basis. They also need to have regular eye exams, kidney exams, and again to maintain and a healthy weight. So some of these things we've already talked about. We need to take a good history, family history. A fasting glucose is a good place to start. Anything above about 110, 120, you need to be investigating. Oral glucose tolerance test. You don't see them doing a whole lot of those anymore. You see them more with pregnancy. But basically, they'll have a patient NPO after midnight, come in, they'll do a fasting glucose, and then they'll give that patient generally a sugary drink. A lot of places just have the patient drink a 12-ounce Coke, maybe a candy bar, and then they do blood tests at 1 hour, 2 hours, and 3 hours. Other blood tests that we need to be looking at as well, of course, checking their urine test. We discussed any type of albumin in the urine is abnormal. It shows that the body is breaking down uh, sorry about that. So albumin in the urine is an early stage indicator for diabetic nephropathy. So the ketones in the urine or a breakdown of the ketone bodies, which means there is a severe lack of insulin. And then just looking at your creatinine for kidney function to help. It would also help stage the level of chronic kidney disease. Urine glucose testing is not accurate, and they don't use it for urine management. The glycosylated hemoglobin assays is basically the hemoglobin A1C, which checks your blood insulin levels over 3 months. So this is just one of the questions I've got in here. Sorry, I got lost on some of my slides here. It went too far on me. This just shows the testing sensation on the feet to see how much sensation the patients have. You have this little filament which looks basically like a toothpick, and this shows you which areas to check on your left and the right foot, and you just poke it there and ask the patient if they feel that or not. So treatment options, I'm not going to go a lot into this. We know that there are oral medications for patients, insulin, of course, watching their nutritional eating plan, exercise, and then surgical interventions such as pancreas transplantations. There is a really good chart in the book that goes over all your types of insulin, what their peak of action is. Most of your fast-acting insulins work within about 20 to 30 minutes. Please look over your insulin dosages and the medications. You may see some questions. I won't go anywhere in depth, but you need to kind of look over those insulins and know where they react and how they react. And then also get into your basics book. Your basics book has a really good chart on page 263 that goes over the insulins as well. And it also has a lot of the majority of the information that I have given you here today. So patient education, again, they need to know how to properly store their insulin. Most insulins need to be stored in the refrigerator. How to prepare their dose, wiping off the top of the bottle, making sure they don't shake it, that they roll it, and then, of course, how to monitor how to use their blood glucose machine. Infection control measures. All patients are at risk for increased infection, especially if they get any types of sores on their body, because the infection makes the insulin levels increase, and then that puts that patient in increased risk for diabetic ulcers, and of course appropriate diet therapy. So this is the end of this lecture. Again, please make sure you read your chapter, look over all, there are multiple charts in here that take a lot of this information and just put it into one page, and please get it into your basics book. Thank you.